presentation today will be held by Professor Linda Hill, who I would like to welcome to UC Berkeley. Dr. Hill is a professor at the Department of Family Medicine and Public Health at UC San Diego. And she's done a lot of research and prevention research, particularly. So things to do with driving safety, physical activity, and obesity, and many others. And today she'll be presenting the early results of a study called Long Road, which basically explains how factors including social, medical, behavioral, technological, and environmental affect driving behavior and safe driving, especially among old adults. So let's please welcome Professor Hill, and I'll pass on the floor to you.
Thanks very much. So a couple of disclaimers. The first is that I have a lot of questions, but not all the answers, and I'm really counting on you to actually help me understand this data that we're getting out of this database. So I really, interrupt me at any time. Let me know if you have questions about what I've presented. The data that I'm going to show you is a lot. I'm really excited about the work we're doing, and I tend to get a little carried away in terms of death by PowerPoint. I apologize for that. But I wanted you to be able to see the breadth of topics that we're covering in this study, in the hopes that some of you may be interested in collaborating on this. We have opportunities for students, and I'd welcome the chance to delve further into some of these areas. So I do want to acknowledge the other members of the Long Road team. This project was started about 5 years ago, and the AAA Foundation for Traffic Safety, which is the nonprofit arm of the AAA insurance company, they funded Columbia and the University of Michigan Transportation Research Institute to be co-PIs on this project, and then identified 5 cities across the United States to recruit subjects. And the idea was that each of us would recruit 600 people, and these are co-authors I'd like to particularly acknowledge because I used some of their slides. So here are the cities that are involved. You can see that Cooperstown is really our most rural setting. Ann Arbor's a little bit rural if you've been to that area, but also close to Detroit, Denver, San Diego, and Baltimore. And the purpose of Long Road's, this Long Road project was to answer these questions. We know that these are all related to the older driver, and we know that the older driver sometimes develops physical, cognitive, frailty issues, medication issues that might interfere with driving safety, but these have not been well characterized. For the last 15 years, I've been doing a lot of work with trying to educate physicians on the older driver and trying to get them interested in injury prevention in the hopes that they will talk to their patients about maybe medications that impair driving safety. But the tools that I've had to do that have been very blunt. And I've told physicians, you need to do screening for vision, frailty, and cognitive function, but nobody's sure exactly how bad does your vision have to be before you start to get crashes, or just how much cognitive impairment do you have before, if you've been driving for 60 years, when does it catch up with you? And these questions haven't been very well answered to date. And part of the problem has been that most of the studies to date have been retrospective or cross-sectional or large databases. Just to give you an example, we looked at the relationship between depression and driving crashes and antidepressants and driving crashes in a meta-analysis. And what we found is that depression increases crashes 2 times and antidepressants by 0.4. So, by 1.4. So what's the problem with that? What's the problem with what I just said? Depression and antidepressants. How are they related? So how did we know the people who were taking the antidepressants, were they still depressed or not? So was it the drugs that were causing the problem, or was it the depression that was causing the problem? These are some of the issues that have come up methodologically. Well, so now we have a prospective study where we're actually asking people what medications you're on, and we're testing them for depression. And the same goes across multiple medical problems. We're asking people if they're on hypertensives, and we can find out what their blood pressure is. So this is the concept. We're collecting a huge amount of data on these people. So the first thing you should know, especially from an engineering point of view, is we have a GPS accelerometer in the UBS port of their car, and every move they make is being recorded. We know if they're speeding, we know if they're decelerating, we know if they're driving daytime, nighttime, and so on. We're also doing a vehicle inspection, looking for what technology they have on their car, as well as bumps and dents. We're asking them what they think they have on their car and whether they're using those technologies. I'll show you some of that data. And we're asking them a lot of questions about their health. In these in-person assessments, we have them, we do frailty testing, vision testing, including contrast sensitivity, memory tests, and so on. We look at their medical records. We get from the DMV their driving crash records, and if they got citations. So what's the next thing you're thinking, having told you what the structure of our project is? What are you thinking? Who signed up for this study? Right? How did we recruit 3,000 people who would record their every move and give us access to their medical records? Yeah, we did, but this is how. We mailed out 40,000 letters to people and followed up. We pre-screened charts. We mailed 40,000 letters across the country. We followed up with calls, and we got, I think, a decent recruitment of 7.3, all things considered. And this is our sample size, our sample. So we wanted to have a pretty even split in ages. Not too bad. It was harder to recruit the older adults. They had to be driving, and they had to not have dementia to start in our study. The other thing you'll notice is we have a very white population and quite well educated, which I think is influencing some of the data that I'm going to show you, and also a fairly wealthy population as well. And this is how it goes. We did an in-person visit at baseline, and then every other year we do it by phone, and then we bring them back. And the concept is that we're going to keep this up. This is, of course, as usual, dependent on funding. And this is just our site, just to give you an idea. We recruited we recruited people. We reached 2990, and then the first year means that did we bring them back for follow-up? We did a pretty good job of getting almost everybody back. The second year people are still being brought back, and now we're in our third year of data collection. So let me show you some of the outcomes that we got. So these are surrogate safety driving measures, because not very many people have crashed. I mean, it's a good thing, right, that these older drivers aren't getting into a lot of crashes, but it means that we're having to use these intermediate measures of driving outcomes. So hard braking events, a near crash, speeding events, they had to be going 80 miles an hour for 8 seconds to be called speeding. And right to left turn ratios. So why, who knows why we care about right to left turn ratios? who can hypothesize. Anybody.
Do you see someone coming in the back?
Different than that. This is the concept of you have a choice of turning left at an intersection, but you're feeling insecure about that. It's kind of scary. You have to pay attention to both the light and the oncoming traffic. So instead, you choose to make 3 right-hand turns. This is what's driving this ratio.
I have a question on the
Yeah.
other metric. The heartbreak, is that a proxy for bad or good driving? Because one way to look at it is to say, okay, that person is not careful and therefore keep braking because they get in trouble. Another one is like once in a while you brake and it's a good thing because someone is doing something stupid at you. So in general, when it's classified, does it count for good or bad?
Bad. It's generally the people who aren't judging well enough, how they're coming up behind somebody and they're having to brake repeatedly.
Okay.
Yeah. So when we looked at the patterns, you can see that one of the patterns is that people start this hard braking thing more as they age, but the speeding goes down. So that's one of the patterns we saw. And the next thing we looked at was the difference in sexes. I should have asked you to guess first, but it's probably what you would have guessed. So who's driving more? The men in this cohort are driving a little bit more than the women, not tremendously more. But the other thing is that there is a pattern in terms of the women are hard braking more and the men are speeding. Is that what you would have guessed? I don't know, in your own experiences. You don't see the guys speeding more? It's just my husband. Okay. All right. So the other thing that maybe isn't a shock is that the rural sites are the ones that are driving more, probably because they have to get around and also have less access to alternative transportation. And it's in the urban settings that all the hard braking is happening. But you can see from the plots that there's tremendous variation. And the other thing is that people are speeding a lot more in the city. That might not have been something that you would expect. So then this is
Speeding is always defined as over 80 miles per hour.
yeah. No, that, as we discussed earlier, that data exists. More detail about the speeding, but this is what I have to present for you right now. So what about the medical conditions of this group? Are they a very sick group? I mean, as I said, they had to be driving at least once a week, and they couldn't have dementia. They were a pretty healthy group. We're actually a little bit worried about that because we were wanting to see, what are the predictors of cessation? What are the predictors of crash? This is kind of a safe group that are kind of healthy. So we're having to wait longer to get some of that data than we wanted. But nonetheless, their lifetime diagnosis of all of these conditions was fairly high. And then when we ask the question, if you have this condition, in the last 12 months, did this condition make you drive less? So maybe you had a knee replacement and you were, post-op, so of course you're going to be driving less, or a hip replacement. So those are pretty logical. People who had surgeries, some of them are a little surprising that only, for example, 6.8% of people with traumatic brain injury reduced their driving. Seemed rather low. So now we come to some interesting parts of what medications, how are medications associated with some of the outcomes. We know that polypharmacy is a big problem in the older adult, that even the more medication you take, it's associated with mortality and other outcomes that we care about. Part of that's because it reflects that person needed a lot of medicine to treat their conditions, but also there's probably some drug interaction and side effects going on that are contributing to that. We wanted really accurate medication, so we made people bring in their brown bag. We didn't want to just look in the medical record, which we had access to. So I'm a practicing physician in a nonprofit community health center. Almost all my patients are foreign-born because I have a refugee clientele. And so I don't want to ask them, some of them don't read English very well. I get that that group's not going to give me a very accurate list. However, what's been found is that almost all the other populations don't do that good of a job either of bringing in an accurate meds list. And so we felt that this was absolutely essential. We make people just gather everything up that they're taking and bring it in. And what we found is there are a lot of drugs. So we coded all the drugs to this drug formulary that's well accepted by pharmacists so that we could batch them into categories. And this is the plot of how many drugs people are on. So I think this is a lot. I mean, somebody out here, you can't see it, but somebody out here is on 51 medications. Even your average person is taking 6.5 medications that were in the formulary and another couple of medications that were not in that formulary. So people brought in witch hazel and some kinds of herbal remedies and homeopathy and this kind of thing. So when we looked at what kinds of drugs, 19% of the drugs were cardiovascular. Vitamins were a big factor. Central nervous system drugs, electrolytes. So I'll show you some of the details. And then this just to say that 73% of the clients are taking cardiovascular drugs, which is another way of looking at it. They only accounted for 19% of all the drugs because people were on so many, but 73% of people are taking it. And then if we drill down further on that list, people were on, these are the actual subcategories of drugs people are on, which maybe is of less interest to you than me. I thought this was like fascinating. So we then looked at, we did regression analysis to look at how are these drugs associated with these outcomes that we cared about. And this is where I could really use some help. So as I said, the mean number of medications, if you include over-the-counters, was 8.37. And we extrapolated how much people are driving. As I showed you the driving data, they're driving over 9,000 miles a year. The mean number of speeding events per 1,000 miles was 8.26. I don't know what that is for you. I don't know if you have any sense of how often you're over 80 for 8 seconds for every 1,000 miles you go. The mean right to left turns, that's actually 0.93. I'm sorry, that's an error. So as a group, people were making more left turns than right turns. And the number of decelerations was 5.47 per every 100,000 miles. So first, let's look at the speeding. So people who drove a lot were more likely to speed, males, Asians. The negatively associated, the kind of protective variables were if you drive a lot of days, but you're not driving a lot of miles, you're not as likely to speed. And if you live anywhere but San Diego, you're less likely to speed. So I don't know if you've driven in San Diego, it's a nightmare. But it was really nice to see that validated. So then let's look at this sudden braking. So who's doing the sudden braking? So it's people who are on more meds rather than less, women, non-white status, and living in a metropolitan area, which totally makes sense, and I showed you some of that earlier. Again, protective was not living in San Diego and driving more miles. So then let's get to this right to left turn ratio. So what do you think's the difference between I'm choosing to make 3 right-hand turns then a left versus the braking and the speeding? Like, how do you think about those two behaviors?
So that's more kind of protective behavior.
Right. You're choosing to do a more protective behavior, whereas speeding and braking are a little bit involuntary as part of your pattern, whereas you're choosing to be safer. So, people, yeah.
Well, I mean, it's the same thing, but it just, when you have to cross the other lane of traffic, you have to make a judgment about what the other cars will offer.
Right.
And there's so
Yeah.
many variables, but I can just stay near the curb all the way around.
And you can make that choice. So who's making that choice? It's as we age, we're making that choice. And people who are living in Denver or Ann Arbor are making that choice. Whereas people in Cooperstown and Baltimore were not. Maybe Cooperstown is our rural site. And people who have a higher income were not making that choice. So I was trying to think, like, what does having a higher income have to do with making the choice to not turn left? Maybe your car's better. Maybe you have front warnings. We'll be able to look for that. I haven't yet. This is just these associations. Yeah.
Have you looked at how the city urban layout is? Does perhaps Denver and Ann Arbor have like more right turn only, or perhaps larger lanes, something like that?
I haven't looked at that, but it's testable. See me afterwards if you want to explore that. So we then took a composite risk variable and we put those 3 factors together, and it sort of makes sense. It's people who are the high-risk drivers for these intermediate variables are people who are on a lot of drugs, driving a lot, older, Asian or other race, and living in a metropolitan area, whereas again, living anywhere but San Diego is protective. So now let's look specifically at the medications. So the only medication that was associated with speeding was CNS. So these are the things that they call CNS drugs. So it's your Advil, your Oxycontin, anticonvulsants like Dilantin, anti-Parkinson drugs, things to keep people from throwing up. So those things were associated with speeding. So what's the biological plausibility here?
The stimulant seems to be the representative.
That one I can understand, but maybe the others are kind of clouding good decision making, and people aren't paying as much attention to the freeway. They're not as responsive to the speed limit. So we looked at the decelerations, and the drugs that are called hormones were associated with decelerations. So insulin, estrogen, corticosteroids. So why somebody on these drugs is braking more again? I was kind of hoping you'd tell me. And then lastly, right to turn ratios. I thought this was kind of interesting. So because this is the most voluntary of them. So people on antihistamines are choosing to make those 3 right turns. Maybe they're feeling particularly insecure. I don't know if you've taken one of these cough and cold medicines that has antihistamines in them. They make you really feel really drowsy and kind of fuzzy-headed. So maybe people are feeling that way. Whereas people on vitamins, this was protective. But maybe people who take vitamins are kind of health conscious, and they're also doing other things for their health, so they're feeling pretty confident. These are some of the thoughts that I was trying to put it together. So again, when we look at the composite, it was hormones, GI drugs, cardiovascular, and CNS drugs that were associated with this composite risk variable. And electrolytes were protective and vitamins. Electrolytes would be like potassium, drugs to treat gout. We're probably, these drug categories are very broad, and we're going to have to drill down in order to better understand it, and certainly in order to give any guidance. So I'm going to show you some of the in-vehicle technology. So we listed all of we found all of these different types of technologies on the car, and all of these adaptations that people had used. So we wanted to find out, well, if you know, first of all, how much of these do older drivers have on their car? So you can see a lot of people had integrated Bluetooth, but very few people had night vision enhancement or semi-autonomous parking assist, for example. But we also wanted to know, if you have this technology, do you use it? So here's the pattern here, and I'll try to walk you through it. So the black means they used it a lot, and the royal blue means they didn't use it much. So some technologies, as you know, some technologies you are a passive user of them. They're on your car. For example, forward collision warning. You'd have to go out of your way to turn it off, right? So all black. Most people didn't bother to go in. If they had it, they just kept it on and they used it. But the people who had semi-autonomous parking assist, they weren't using it. Have you tried it?
No, I haven't, but this gets to a point that I was hoping would come up eventually, which is that I was with my mother when she was recovering from her last big illness, you know, they were like, well, we drive with you and see how it goes. But then she was in worse shape. She was so nervous about being watched. And so the semi-autonomous is a case of like being supervised. So they're going to hate that. but the cheap, drowsy driver, well, that makes, if I'm asleep, then, I mean, that just seems obviously clearly good. But voice control? No, I don't
Right.
really negotiate with my car what to do. And assistance is kind of in between because it's a little bit peer-to-peer. but I think so, yeah. I think that's a really big issue for all of us.
Yeah, it's interesting that if we have these safety features in the car, then we have to set them up that you don't have to engage them; they're automatic, right? Yeah. And then we ask them, if you have one of these technologies, how did you learn how to use it? And everybody's like, I figured it out myself. Or 13% said, I never learned it. But only 11% used the owner's manual, which, and they were all guys. I'm sorry, they were all not guys. So, yes, I totally ruined that joke. But, all right, so we also asked them whether they thought these technologies were good safety features. Did they think that they were valuable? And I think a little bit surprising, you know, I don't know why they wouldn't think that it's fatigue and drowsy alerts or adaptive cruise control or nighttime vision enhancement was a perceived safety feature. Maybe they already thought they were safe drivers. We did ask them that. I just don't have that particular correlation.
So the first one, the navigation assistance, was rated highly, yet we know that they don't use it.
Right.
So basically, they're saying it makes me appear like a safety driver.
Yeah. A lot of people were using aftermarket modifications, things that didn't come with their car, but they were adding things, mostly seat cushions and mirrors, and the other stuff was a lot less. You can see that. Most of them said that they taught themselves how to put those things in. So now we come to the part on alternative sources of transportation, and this part of the study was done by asking people whether they had in the last 3 months, other than driving themselves, used other ways to get around. And the analysis was looking at whether they used 1, 2, 3, or more other ways of getting around. And this is a super, super busy slide. You can see that men, if you look at sex, male, no other alternatives, men were more likely to not have another alternative. People did have, I think this is a little counterintuitive, more people who were in the 75 to 79 age group didn't have any alternative transportation. People who were not married had no other alternative, and people who were non-white were less likely to have an alternative. So, the other thing I think is interesting is that people in low-income housing, households with low income, were less likely to have an alternative. And then when we look at what were they using, the majority of it was they were a passenger in a car, but a fair amount were using 17% trains or subways, 16% rideshare, 12% public buses, and other modes of transportation. And that included our active transport, for those of you in the audience. So women are more likely to be passengers, but less likely to report other sources. But most people had at least one other source. And then I'm going to go on, for the sake of time, to alcohol use patterns. So these were the questions that we asked. And you may think to yourself, well, why are we worried about alcohol use in the older adult? Well, come to find out, this older adult population is actually drinking a fair amount. So we asked, in the last 3 months, have you had anything to drink? In the last 3 months, how many days did you drink? And how much did you drink? And this question is, how often do you drive even though you realize you might be over the legal alcohol limit? Now, unfortunately, when this survey was developed a few years ago, nobody put in the last year. So there's some concern that people might read that question and think, have I ever in my life driven over the limit, even though it's in the present tense? How often do you drive? But I wanted to make you aware of that so that when you see the outcomes. So the amount that the older adult can drink has just been downgraded. So no more than 7 units a week. And over that is considered high-risk drinking. So do you know what it is for, in general, for women and men? What's the limit before there's the risk of health effects? How many units of alcohol on average a day or a week? Somebody said 2? Yeah, so 2 for women and 3 for men, although is where it starts to be high risk. And now they're saying, so women can't have more than 1 drink a day or 7 in a week, and men can have 2 or more, because at 2 and 3 you're starting to get high risk. So that's recently lowered. But look at these older drivers. 72% of them have been drinking in the last 3 months. So this is higher than has been reported in other studies of older adults. Now these are older adult drivers who are still actively driving, and as I told you, they're wealthy, relatively well educated. And 15% reported this definition of high-risk drinking, and 3% said that they report driving over the legal limit at least occasionally. We thought that was a lot. When we looked at what predicted high risk, what predicted driving over the limit, at least occasionally, it was people who were engaged in high risk drinking. Totally makes sense. It also was part of a pattern. So we asked people in another part of the survey, what do you do if it's like the conditions are very hazardous, it's snowing or raining outside, which, not in San Diego. But what do you do? Do you postpone your trip? Do you delay your trip? And so people who avoid hazardous driving conditions were also much less likely to drive over the limit. If they lived in Denver, and if they were female, they were also more likely to drive, less likely to drive over the limit. And for the first year that we did this study, we looked at cannabis. We didn't ask in San Diego because it only got legalized in January. And from an IRB point of view, it gets risky if you ask people about behaviors that are illegal. So we waited until January to ask that question in San Diego, so I don't have that data yet. So this is just Denver. Denver does look like the other sites, about the same age, about the same ratio, and we asked, have you ever used cannabis, how many times, do you drive a motor vehicle within an hour of using it, and in the last 30 days, have you driven within an hour? So almost everybody answered the question. 41% of people said they had ever used cannabis. The 9% said they used it in the last year, so not a tremendous amount. Maybe you think, I don't know if you think that's high or low. And only 5 participants said that they had used marijuana within an hour of driving. So who were these cannabis users in our study? Well, they tended to be the younger of our older drivers. They tended to have less education, to have less income, to report to us that they had mental illness, depression, anxiety, problems with anger, less emotional support, and more social isolation. So what's the question here? Is the cannabis causing the association? Or, or are they using it to treat their anxiety? We talked, earlier we met and we talked about the OTS commercial. Have you seen it, that they took off the air? That says, what's it called? I use cannabis for my anxiety. I use cannabis for my nausea. It sort of goes on all the good reasons that these people were using cannabis, and then it says, but don't use cannabis and drive. Brought to you by the Office of Traffic Safety. And I guess they got into a huge
So the
amount.
message is you should only drive when you're anxious.
That's the end of my slide deck. As I said, this data brings up more questions than answers. There's the opportunity for you to collaborate with us. We have so much more data than we have the time to analyze. This is just the data after our first year. Our second year has closed. So we would welcome the opportunity to work with you. And I'm open for questions now.